So welcome to the sixth webinar session of the EuroBloodNet topic on focus on thrombotic microangiopathies. As you know, those are online educational sessions for health professionals, and this program has been developed in collaboration with the French Reference Center for Thrombotic Microangiopathy, CNR-MAT. The main objective of the program is indeed to disseminate very innovative topics among hematologists, internists, nephrologists, pediatricians, or other care providers that are interested in the topic of thrombotic microangiopathies. And so we give visibility to the last cutting-edge advance in this field of rare hematological disease. Today, we are going to talk about organ dysfunction in TTP. And with us, there is the Dr. Mariotte, who graduated in internal medicine in 2009 and in intensive care in medicine too. And he has been studying thrombotic microangiopathy since 2007, starting with a master in hemostasis and vascular biology at University of Paris. And he has since published several articles on the epidemiology, diagnosis, and management of severe thrombotic thrombocytopenic purpura. Since 2014, he's working at the intensive care of the unit of Hôpital Saint-Louis in Paris and a constitutional center of the thrombotic microangiopathies, already named the French National Reference Center, managing over 15 new cases of TTP per year. So, dear audience, please welcome with me Dr. Mariotte, and the floor is to you. Thank you very much.
Thank you very much for this kind introduction. So, ladies and gentlemen, it's a pleasure for me to be here today to have this talk with you about organ dysfunction in thrombotic thrombocytopenic purpura. Here are my conflicts of interest. And so the learning objectives of this session will be for you to discover or to rediscover the spectrum and mechanism of organ involvement in TTP, to understand the prognostic value of specific organ involvement in this disease, and to learn about the risk of long-term sequelae in TTP patients. As you know, TMA syndrome is characterized by the presence of microvascular thrombosis in organs. It's rarely diagnosed on organ biopsy, but rather on the associations of more simple signs to collect, that are the association of mechanical hemolytic anemia with negative DAT and presence of schistocytes in blood smear, peripheral thrombocytopenia, and various signs of visceral ischemia potentially ascribable to microvascular thrombosis. Once this diagnosis of TMA syndrome is made, you have to find the etiology that can be TTP, but it's far from being the most frequent etiology, as we will see. To help us to find this, the etiology of the disease, we used to rely on a clinical classification of TMAs, where thrombotic thrombocytopenic purpura was defined as TMA with a prominent neurological involvement, and hemolytic and uremic syndrome as a TMA with a predominant renal involvement. The problem was that patients often present with both organ involvement, and due to this overlap, a lot of patients could not be classified correctly. So we moved to a more pathophysiological classification that helped us to identify clearly three items of the TMA syndrome, thrombotic thrombocytopenic purpura, classical or typical hemolytic uremic syndrome, and a typical hemolytic uremic syndrome. In this modern classification, thrombotic thrombocytopenic purpura is defined as a TMA with a severely decreased ADAMTS13 activity. This ADAMTS13 deficiency can be secondary to mutations in the ADAMTS13 gene, which is responsible for most pediatric forms of the disease, called the Upshaw-Schulman syndrome. In adults, it's mostly acquired through anti-ADAMTS13 autoantibodies. It's an autoimmune disease with autoantibodies directed toward ADAMTS13. TTP, as you know, is a rare disease with an incidence estimated from 1.5 to 6 new cases per million per year. And as you see on this slide, it's far from being the most frequently told etiology of TMA. In this large cohort of patients with TMA syndrome, only 6% had primary TMAs, including 3% of patients with TTP, far behind secondary TMAs, which represents 94% of cases in adults. How does it work? Well, ADAMTS13 is a von Willebrand factor specific cleaving protease. So under high shear stress conditions associated with the microcirculation, and only in those high shear stress conditions, large von Willebrand factor multimer unfold. And when they unfold, they become highly adhesive to platelets, but they also expose their site of cleavage for ADAMTS13 to degrade them in smaller multimers that display no activity toward platelets. So if for any reason you have no ADAMTS13 activity, this will lead to the accumulation of this unusually large multimer of von Willebrand factor in the microcirculations, which leads in turn to the formations of microthrombi in the microcirculation, with thrombi that are very specific because they contain almost only platelets and von Willebrand factor. And this explains to you why TTP is a microvascular disease. It's because it's only in the microcirculation that large von Willebrand factor multimer can unfold and display and become adhesive to platelets and cause platelet aggregation. So clinical involvement of TTP is quite wide, but mostly limited to 4 organs. As you see, involvement of the central nervous system is the most frequent clinical anomaly, but it's far from being constant. Some patients may not have central nervous system symptoms at presentation. Kidney involvement is far from being rare. A large proportion of patients will have kidney function anomalies. And you should also seek involvement of the heart and of the gut. This is clinical involvement. If you look at autopsy data, patients dead with TTP, and data of autopsy shows us that TTP is really a multi-system disease with the involvement of almost any organs, and you will find microthrombi anywhere in the body of this patient dead with TTP. And there have been descriptions of thrombosis in the adrenal glands, spleen, the skin, the bone marrow, and even the lung that is never clinically affected in TTP. We'll start with neurological involvement. You see that neurological symptoms are very miscellaneous in TTP. Most patients will present with headache. That can be the only symptoms in about 40% of the case, but you see that they can present any symptoms, going from stroke-like symptoms to seizures, confusions, and even coma. Cerebral imaging will most of the time be normal. If you perform a CT scan, you will find anomalies only in 19% of cases. If you perform an MRI, it's only 40% of the case will show anomalies. That's because microvascular thrombosis is not systematized and sometimes too little to be seen with cerebral imaging. If you see anomalies, they may involve almost all parts of the brain. So I told you the core mechanism of cerebral involvement in TTP is microvascular thrombosis. That may be too little to be seen with imaging, but sometimes you will see large defects on CT scan or MRI with ischemic stroke or hemorrhage, secondary to ischemia and severe thrombocytopenia. But most of the time, brain imaging will be normal and will characterize transient ischemia. And some of the time, we'll see highly reversible syndromes like posterior reversible encephalopathy syndromes or reversible cerebral vasoconstriction syndromes. That may explain why the short-term outcome of TTP patients with central nervous system involvement is usually good, at least if you use a classical neurological scoring system like Glasgow Outcome Scale or ranking score. This patient will recover under therapy, under modern therapy, including therapeutic plasma exchange, steroids, rituximab, and capecitabine. If you look at the long-term prognosis of these patients, probably different because these patients seems to be at higher risk of cerebral complication during follow-up, and particularly ischemic stroke with much higher frequency during clinical remissions and an age and sex matched reference population. And interestingly, in this work, this risk was limited to patients that recover an ADAMTS13 activity that is subnormal. The normal range for ADAMTS13 activity is between 50 to 150% of a pool of healthy donors. And in this study, the risk of stroke during follow-up was limited to patients that had less than 70% of ADAMTS13 activity, which may identify a population that is particularly at risk and may require particular attention during follow-up and perhaps specific interventions to prevent this risk. Another long-term sequelae of TTP may be headaches. As I told you, most patients will present with headache at diagnosis. They may be beginning the first symptom of the disease, but they may persist. And in this study, it was shown that TTP patients in remission present with severe invalidating headaches more frequently than the matched population. And with these scores, the HIT scores, the author have shown that these headaches have a level that severely impact the ability of patients to function normally in their usual life. So this also may require specific interventions. And last, for neurological involvement, if standard cognitive performance of patients are usually preserved, if you use simple tools like mini mental states, if you use more specific, more precise tools, you will see that these patients' cognitive performance are durably altered, and patients will tell you that they're not the same as before TTP. They have difficulties with short or long time memories. They have difficulties with for the execution of complex tasks, and so their cognitive performance are not intact. And this can be quite invalidating for patients. And last, probably a consequence to this, the prevalence of depressive symptoms and depressions are more frequent in this population, which leads to severely decrease quality of life in these patients. And when studied, it has been shown that the survival of TTP may have significantly altered quality of life, similar to that of, for example, cancer patients. We talk about now cardiac involvement. If you search for cardiac symptoms in your patient, you will find them in about 20% of the patients, consisting of cardiac symptoms with angina, congestive heart failure, and syncope. If you're researching cardiac events which are more than cardiac symptoms, but include biomarkers of myocardial dysfunctions from ECG modifications, arrhythmia, cardiac function study with ultrasound or invasive techniques, you would see that some patients present with cardiogenic shock and even sudden cardiac death. And this will concern more than half of the patients. If you consider only the most severe patients that died with TTP, all of them will present with a widespread microvascular thrombosis of the heart. With a modern technique of dosage of cardiac enzymes with ultrasensible troponin, maybe as much as 70% of the patients will have troponin elevation. That may be the only symptom of cardiac involvement. If you look at pathology, patients dying with TTP will have macroscopic cardiac ischemia, here subepicardic myocardial ischemia. And under microscopic exam, you will see this same hyaline thrombi composed of platelets and conjugal factor in the microvessels of the heart with foci of hemorrhage and necrosis with contractions and forms. It's very important to seek systematically cardiac involvement in TTP patients, as this cardiac involvement is constantly associated with worse short-term outcome. In this study, it was associated with almost 3 times higher risk of early death. So you need to dose troponin even in patients that don't complain about cardiac symptoms. And about long-term follow-up, TTP patients seem to be at higher risk of cardiovascular mortality. I told you they present with a higher risk of strokes, and they present with higher risk of chronic arterial hypertension. In this study, 45% of patients, which is more than matched population prevalence. And this may require also a specific therapeutic intervention. Concerning kidney involvement, I told you that kidney dysfunction is quite prevalent in acute TTP. It's usually not very severe, but if you take any kind of kidney involvement, you see in that series of patients with critically ill patients and requiring ICU admission. Acute kidney injury, using the KDIGO criterion, was present in almost 60% of patients. It was usually not very severe, with median serum creatinine levels of 1.6 milligram per deciliter, but corresponding to stage 2 and 3 KDIGO AKI staging in more than half of the patients. why is there an kidney dysfunction in this patient? Well, we suppose it's due to microvascular thrombosis, but of course we have no data on the histology of kidneys of this patient because they present with a mild kidney dysfunction and they are severely thrombocytopenic, so they never undergo kidney biopsy. All we have is autopsy data concerning the most severe patients, where we may find the same hyaline thrombi in the vasculature of the kidney, in the glomeruli and the arterioles of the kidney. It's very different from what you see in the deceased patient with HUS, where you have very diffuse and severe microvascular thrombosis of the kidney with often cortical necrosis with thrombi that are different from those of TTP as they contain fibrin. The long-term prognosis of this patient is very favorable. Most of patients recover and they recover a glomerular filtration rate similar to match control. But if you take the most severe patients, the series that I talked to you about 2 slides ago, with a high prevalence of kidney dysfunctions at diagnosis, well, some of these patients, about half of these patients at 6 months, will have criterion for chronic kidney disease according to KDIGO criterion. And some of them may remain dialysis dependent. But in this series, it was only the 3 patients with the occurrence of TTP in association with another condition that was an autoimmune disease with renal involvement. But so the long-term prognosis of kidney involvement is globally good, even if at 6 months, a significant proportion of patients may have criterion for chronic kidney disease. Concerning the digestive involvement of TTP, we have few data. We consider that about 1/3 of patients will present with abdominal pain at diagnosis. We presume it's due to gut ischemia. Some patients may present with diarrhea, sometimes bloody diarrhea, which is clearly not the hallmark of typical HUS. And significant proportion of patients have a pancreatic microvascular thrombosis found at autopsy, whereas clinical pancreatitis is quite a rare occurrence in TTP. So we don't really know, we have no data apart from autopsy data in these patients. And beware, because TTP-like syndrome, TMA syndrome with normal ADMTS13 activity or moderately decreased ADMTS13 activity have been described secondary to acute pancreatitis in some patients. So maybe it's not the consequence, but the cause. One confounder to remember is that in adults with TTP, it occurs in association with another condition in about half of the case. In half of the case, we'll find another condition of disease associated with TTP that can be another autoimmune disease, an infection, pregnancy, some cancers, HIV infection, transplantations, or drugs uptake. And sometimes the organ dysfunction you will see in this patient won't be related to microvascular thrombosis and TTP, but rather to the involvement of the associated condition. For example, in patients with lupus-associated TTP, severe renal insufficiency or neurological symptom may rather be related to lupic glomerulonephritis or neurolupus than TTP. So always remember that. Last thing is, I told you TTP was a microvascular disease, but remember that macrovascular thrombosis can also occur in some patients. It can be venous thrombosis for example, deep vein thrombosis in bedridden patients undergoing therapeutic plasma exchange. These are probably no link with TTP. Catheter-related thrombosis occurs quite often in patients with TTP when they get better. So it should probably systematically be sought in patients with TTP. And some patients will present with macrovascular arterial thrombosis. In this study, arterial cerebral infarct. This is probably due to pre-existent macrovascular disease with critical or pre-critical stenosis of the macrovessels of the coronary arteries or the cerebral arteries, which can reproduce the high shear stress conditions necessary for the large multimorph factor of vibrance to unfold and to lead to a microthrombosis usually, but in that case perhaps to macrothrombosis. So it's not completely excluded that patients with TTP may present also with macrovascular thrombosis, even if it's quite a rare event, but it may become more frequent as our population of patients is aging. So I'm nearly finished. My take-home message would be that organ involvement is highly variable in TTP and clearly is not restricted to the central nervous system. Cardiac involvement has been associated with worse short-term outcome, and neurological involvement has been associated with worse long-term neurological or neuropsychological outcome. Thank you for your attention.
Thank you very much, Dr. Mariotte. So first questions. Is there data on the impact of modern therapies like rituximab and cabazitaxel on long-term recovery of organ dysfunctions?
Okay, that's a good question. As you know, the standard of care of TTP has quite changed during the last years, and now patients generally receive rituximab and cabazitaxel in addition to therapeutic plasma exchange and corticoid steroid therapy. This has led to a great improvement of short-term outcome of this patient as mortality has dropped from 10, 15% to less than 5%, but we don't know yet if this has an impact on long-term outcome in these patients. All data I showed you in this presentation was about patients from an era before rituximab and cabazitaxel, so probably this will change in the next year. We will have some data, some new data with the results of the post-Hercules study that is studying patients from the Hercules study the long term at as long as 3 years, and I think we'll have the result at the end of this year.
Okay, thank you very much. I go with the next question. Why do certain organs seem never to be involved in TTP?
It's also a good question, but it's not very clear. As I showed you, if we're talking about clinical involvement of organs, it may be quite limited in most of the patients, but microscopic autopsy data shows that microthrombosis is very widespread in TTP patients. Why some organs are seems to be more preserved than others? It may be due to higher efficiency at producing ADAMTS13 in certain types of endothelial cells. You know that ADAMTS13 is produced in the endothelial cells, and maybe some organs have more performant endothelial cells to resist to ADAMTS13 deficiency. Some cells other than endothelial cells also produce ADAMTS13, and for example, in the liver, that is never affected by TTP. The stellate cells produce ADAMTS13 and may compensate for the deficiency. And last, we have some data about the kidney. In the kidneys, the podocytes seems also to be capable of producing ADAMTS13, which may explain why this organ is relatively preserved from clinical involvement of CTP.
Thank you very much. So there is one other question. How this organ damage overview can fit into a severity classification at one onset?
Good question. Aside from cardiac involvements, no organ involvement seems to be associated with worse short-term outcome. Of course, it's difficult to be conclusive about that because in most parts of the world, more severe patients will go to the intensive care unit and will benefit probably for intensive care unit monitoring. Whereas patients with only hematological symptoms and no clinical symptoms will remain out of the ICU. And most of the data we have is complicated to interpret in this context. Probably patients with multi-organ involvement are higher risk, but it has not been showed with, for example, for neurological involvement of TTP. Patients with severe neurological involvement will have a favorable outcome. So aside from cardiac involvement, I don't think we have data to say that patients that seem to be more severe at diagnosis are at higher risk of death. Of course, if a patient is sufficiently severe to require mechanical ventilation or renal replacement therapy, this organ deficiency, independently from its mechanism, will impact its short-term prognosis. But it's not a sign of severity of the TTP, I think. It's a sign of severity of any disease.
Okay, thank you very much. There is one other question. So thank you very much for this excellent presentation, Dr. Mariotte. I echo the same. It has been really a great presentation. Do you have any recommendation to monitor cognitive performance in the long term? Any recommended scale?
That's a good question, but a complicated one because each center uses different scales for monitoring of cognitive performance. We don't, personally, and we address patients with that complain from cognitive dysfunction to neurologists, specialists of the memory and of the brain functioning. So I'm sorry, I don't have any degree of recommendation of a particular scale. I think it's important to research it to see if there is something you can do to help patients to recover better from this, but I don't know if it's possible. And if this has really an impact on the management of the patient. For now, it's only reserved data, I think.
Thank you. Are there difference in pediatric respect adults?
Yes, indeed. Well, patients with congenital TTP present with if they are not diagnosed early in life, which happens in some cases, and these are patients that are treated with plasma supplementation for their entire life. And if they are not, they will present with recurrent boosts of TTP, and this will lead to more severe organ damage than what is seen usually in adult-acquired TTP, because they make more bouts of the disease, and possibly because a relative deficiency in ADAMTS13 activity is by itself a cardiovascular risk factor. So they have more severe, they display more severe neurological presentations, and they are also the most severely they're also the patient with the highest frequency of renal involvement of TTP, because the kidney seems to be suffering on the long term from ADAMTS13 deficiency. And if there is a genetic mutation responsible for ADAMTS13 deficiency, you may consider the fact that endothelial cells are not able to produce it, okay, but maybe the other cells that may compensate for this deficiency, like the podocyte or the hepatocyte, may also suffer from this deficiency. So probably that's why they have more organ damage. Yes, it's quite different.
Thank you very much. So I have another question. Any organ-specific advice for treater related to peculiar organ damage behind general treatment? Can early treatment preserve organ function?
For the last part of the question, it's really yes. Early treatment preserve organ function. If patients benefit from early therapeutic plasma exchange and other therapies I cited, they are less at risk to develop significant clinical organ dysfunction. So it's very important to treat patients early before the occurrence of severe organ damage. Even if this organ damage most of the time is reversible under therapy. And about organ-specific advice for treatment, there is none. To my knowledge, there is none. We used to give patients with clinical cardiac involvement aspirin or antiaggregant therapy. We used to do this before keplacizumab. For now, we don't know if it's necessary to give aspirin in addition to keplacizumab, but we continue to do this, but we have no solid data to recommend that. And for specific kidney involvement or gut involvement or neurologic involvement, to my knowledge, there is no specific treatment for this.
Thank you very much. So there is another question. I hope to read it properly. If not, please, Dr. Mariotte, correct me. As said, I'm not physician, so I can misspelling something. So in patients with ADAMTS13, lower than 70% during follow-up, what do you recommend?
That's also a good question. We were quite surprised by the finding of Upreti and allied with long-term follow-up of patients with TTP. We didn't have the impression that these patients were at higher risk of stroke, but they published convincing data. So in patients with subnormal LMTF in dosage during follow-up, we would recommend to be particularly cautious about cardiovascular risks and strictly control hypertension, perhaps introduce treatment for dyslipidemia and other classical treatment for the prevention of cerebrovascular disease, but we definitely won't recommend regular brain imaging because it's no use probably, and it's not correlated to the activity of the disease and the risk of stroke. But perhaps in this patient particularly a risk, at least one exam, one brain imaging that didn't have it during the acute phase would be useful to identify patients with already severe cerebrovascular disease that will require a consultation with a neurologist.
Thank you. Would you comment those patients on aspirin? Thanks so much for your excellent presentation.
I spontaneously would, but it's only my advice, and probably I would refer this patient to cerebrovascular specialist to evaluate their risk of stroke and to decide for the best treatment for them.
Thank you.